Welcome to the module on evidence-based practice in physical therapy. During this module, our goals are to define evidence-based practice in physical therapy, to categorize the types of evidence that are typically used in PT clinical practice, and we will also discuss barriers to evidence-based practice, including common flaws in clinical reasoning. Finally, we will discuss the ways physical therapists utilize evidence when working with patients, such as the use of clinical practice guidelines. The term evidence-based practice emerged in the early 1990s as an initiative that was geared towards improving the quality of healthcare using research. One of the founders of the evidence-based practice movement was Dr. David Sackett. He defined EBP, or evidence-based practice, as the integration of the best research evidence with clinical expertise and patient values. It is important for us to realize that evidence alone is insufficient. Clinicians need to be skilled at locating and interpreting the research based on their own knowledge and experience and adapting the findings of the research to best suit each patient's individual needs and preferences. There are many advantages that are associated with evidence-based practice. An evidence-based approach helps reduce variations in patient care and promotes optimal treatment outcomes. This helps to conserve resources and also decreases the risk of medical errors. Unfortunately, many practitioners do not necessarily adhere to evidence-based guidelines. In the past, some studies have demonstrated that there are significant gaps between actual patient care and best practice. In 2004, there was a study done that estimated that more than a third of patients did not receive care that was consistent with current evidence, and more than 20% of patients actually received care that was potentially harmful. This is one of the main reasons that there is such a push now towards EBP as part of the curriculum when training future healthcare practitioners, including physical therapists. As PTs, we can look at the ways evidence-based practice helps elevate our profession as a whole. Better quality care enhances our professional reputation both collectively and individually. When we deliver optimal outcomes, the public increases their awareness of the value of physical therapy services. This also helps improve respect for PTs and our unique skill set among our other healthcare colleagues. Insurance companies and third-party payers are also more likely to acknowledge the value of physical therapy when we can validate the benefits of treatment using objective research outcomes. Within PT practice, there are 5 main categories or domains where research or evidence is typically used. In Domain 1, we can use evidence to help guide us in the choice of therapy or rehab interventions. We can use evidence to find the best approach to prevention and reducing harm. We can also do research or use existing study results to help determine the cause or etiology of certain diseases, impairments, or conditions. Domain 2 creates or utilizes evidence to provide a reasonable prognosis for expected recovery. This includes how long it might take the patient to recover, as well as how much functional return may occur. Domain 3 assists in diagnosis, or determining what the main issues are when we are presented with a set of data that might include things like patient history, as well as findings of the exam and evaluation. Domain 4 looks at differential diagnosis, and Domain 5 deals with costs of care, access to care, and conservation of resources. Focus area for EBP in physical therapy also includes things like selecting the most valid and reliable instruments and tests used for examination. We also can use research or evidence-based practice to find the best ways to interpret data that we find on our examination so that we come up with the most accurate and best differential diagnosis, prognosis, and plan of care. Summaries of evidence-based information can be very helpful to clinicians. Summaries are more time efficient and help provide standardized application of recommendations that are in the form of clinical prediction rules and clinical practice guidelines. Clinical prediction rules help us determine who or which patients might require certain tests or evaluative measures, and helps us to determine how well somebody may respond to a specific course of care. Clinical practice guidelines also represent a summary of evidence for selecting the best treatment interventions based on someone's presenting diagnosis or their signs and symptoms. Later, we will take a closer look at how clinical prediction rules and clinical practice guidelines are developed. Next, we are going to consider different types of evidence. One way we can categorize research is according to the nature of the data. Quantitative studies use numerical data to perform statistical tests and other mathematical operations. Results are represented by things like frequency counts, percentages, means or averages, standard deviations, and procedures or statistical tests that help us examine associations and strengths of relationships among variables. In contrast, qualitative studies use different types of data, such as transcripts and field notes, to explore or describe certain conditions or phenomena. Examples of methods that are used in qualitative research include things like interviews, focus groups, observations, and open-ended questions on surveys that allow people to freely respond to a question rather than picking from a set list of choices. You may also hear the term bench science. This is usually what most people think of when we talk about research. Bench science refers to studies that typically occur in a laboratory setting. Sometimes bench science is further subdivided into two categories, into in vitro studies that involve components of living organisms such as cells and tissues, or in vivo studies, which usually refer to animal or human studies that are done after in vitro studies demonstrate some level of promise and minimized risk. We can also classify research by the type of study design and the strength of the findings. Here you see the hierarchy of evidence represented by a triangle. The gold standard, or at the top, the highest level of evidence, is typically considered to be systematic reviews and meta-analyses. These types of studies are summaries of evidence across a number of individual trials. The summaries are created in a way that not only provides collective data, but it also looks at the quality of the evidence that is being included before it's placed in the summary. So you get two things. You get a summary of the research findings, but you also get some level of quality control to make sure that we're only including or considering studies that are strong and have structured methodology. Next on the pyramid are randomized controlled trials, or RCTs. These types of studies use a number of different strategies to help reduce bias. Cohort studies are next. We will talk more about this type of research during the term, but in general, cohort studies use naturally occurring groups of people to look at outcomes, in contrast with randomized trials where subjects or participants are recruited and assigned to groups. Case control studies are somewhat similar to cohort studies, although groups are usually divided into cases according to the presence of a certain disease or condition, and controls, where people do not have this disease or condition, but share enough similarities with the case group to draw meaningful conclusions. For example, cases and controls may be matched on certain characteristics like age, sex, race, or ethnicity. Cross-sectional studies look at data from one point in time to draw conclusions about associations. Unlike the types of studies higher up in the pyramid, cross-sectional research should not be used to make inferences about cause and effect. Although case series and case reports do not use stringent controls like we see in things like randomized controlled trials, these types of research are an important step in examining data for preliminary studies and investigations on rare conditions or a new type of intervention. Finally, since we said that evidence-based practice also relies on the expertise of the clinician, we should include things like expert opinion and anecdotal information. While these may not be considered formal research, there is definitely value in clinical experience. Also, some of the best research questions are generated by healthcare practitioners who work in the field directly with patients on a day-to-day basis. The hierarchy of evidence is based on the level of control for each study. for each of the studies. In research, control refers to the steps that are taken to reduce bias or the possibility of an alternative explanation for the observed results. This alternative explanations might include things like a confounding factor or variable, or even the influence of chance. This is why all statistical tests include a probability value. The p-value tells us the statistical likelihood that the observed result was due to chance. Experimental research designs have the greatest degree of control. The researcher or investigator deliberately manipulates one or more variables to measure the possibility of cause and effect. Generally, outcomes across two or more groups are compared according to whether or not the people in the group received the intervention. The gold standard for experimental design is the randomized control trial. Quasi-experimental designs usually involve a certain intervention where outcomes are measured before and after. However, they are called quasi-experimental because there is either no random assignment of participants, or there may only be one group with a pre-test and a post-test to help compare results. Non-experimental designs are observational studies where there is no attempt at all to impose control. These types of designs are best used to describe or explore existing conditions or relationships. Finally, case reports or anecdotal evidence pulled from working directly with patients can assist us in formulating questions and designing research with larger samples and a greater degree of control. When patient data are collected using standardized instruments, case studies can be used to generate research questions that are highly relevant to clinical practice. Another way of categorizing research is to look at the continuum from descriptive studies to experimental studies. Descriptive studies look at existing conditions within certain populations. Exploratory studies begin to examine relationships between conditions or variables. And experimental studies manipulate conditions or variables to get more information about cause and effect. Now that we have considered some of the many benefits of evidence-based practice, let's look at some of the potential barriers or things that may interfere with implementation of evidence-based guidelines. Some of the barriers in EBP have to do with the characteristics of each individual practitioner. Hopefully, as healthcare education improves, we will see less of these barriers. Many older physical therapists, myself included, did not receive formal instruction in finding, assessing, and incorporating evidence into daily practice as part of our entry-level PT training. So, unless we have sought some type of continuing education, many of these older physical therapists may still be unfamiliar with evidence-based guidelines. Also, although this is becoming less and less of an issue, some clinicians object to the value of the evidence. They may feel as though our experience in the so-called real world is far superior to information that is obtained through research studies. We need to remember that skepticism does indeed have some value. We should, in fact, question the evidence and assess its quality before applying it to patient care. But, on the other hand, access to evidence does allow each individual PT to use not only their own experience, but the collective experience and knowledge of researchers and practitioners out in the broader healthcare field. When people lack training in evidence-based practice, they typically also lack something called self-efficacy, or the confidence to apply evidence-based information in clinical practice. They may also have low expectations of the potential for evidence to improve outcomes and quality of care. And like many people, let's not forget that clinicians are human, and most of us fear change to a certain extent. We are also sometimes affected by inertia or lack of motivation. This can be exacerbated by lack of time for evidence-based practice in the clinical environment. Another barrier to EBP is that there isn't always evidence available to answer certain clinical questions. You may be presented with a unique patient issue or a new intervention that hasn't yet been examined using clinical research. This is when clinicians should consider collecting data that can be used for a case study or case series. Also, once you leave school, many practitioners no longer have access to a medical library. This makes it hard to find research articles. Professional professional membership in organizations like the APTA can be helpful in this regard. So can professional initiatives such as PT Now or Pedro. PT Now is a website that allows us to access a number of standardized outcome measures developed through the application of evidence. Pedro is a database that contains summaries of evidence according to topics common to PT practice. Other challenges or barriers to EBP come from research design or methodology. Sometimes it can be hard to find studies where the sample demographics match the characteristics of your individual patient. This is especially true for well-controlled studies where stringent inclusion and exclusion criteria lead to the selection of research participants who do not have many of the typical clinical presentations that often involve multiple comorbidities. If we think about the types of people that we see in a clinical setting, many of our patients have not only the disease or condition that leads them to seek physical therapy, but other conditions or diseases that can complicate care and compromise outcomes. Also, while many research studies often involve the application of single interventions delivered in isolation, this is rarely how healthcare operates. Our patients usually receive a number of treatments at the same time, and this can lead to confounding variables within the clinical environment. Another issue comes from the types of interventions that are tested during research studies. Clinicians working with patients may not have access to the same technology and resources that were used in creating the research, and therefore we may not be able to deliver similar care. The next thing we're going to consider is flaws in clinical reasoning and how these flaws could interfere with evidence-based practice. Fortunately, when we are aware of these flaws, we can work towards reducing or eliminating them. Cognitive bias is the inability or unwillingness to change our thinking patterns. Changes in clinical practice based on new evidence can be challenging in this regard. Ascertainment bias is somewhat similar. This is where a healthcare practitioner draws conclusions based on previous expectations. For example, if a PT has worked with a group of patients with occupational injuries or work-related diagnoses and find that these patients have consistently exaggerated or falsified symptoms in an effort to remain out of work or gain money through litigation, the physical therapist may conclude that all workers' compensation patients do this. This perception would then bias future interactions with new patients who may actually have legitimate health concerns. Confirmation bias is something researchers and clinicians both need to be aware of. Confirmation bias involves a selective focus on evidence that does not challenge our existing conclusions. Value bias is where the PT or healthcare practitioner looks at the evidence according to his or her own preferences towards certain interventions without considering the perspectives or opinions of the patient. Emotional or affective bias is similar to value bias, except that the preferences of the PT or clinician aren't necessarily based on objective research data, but rather on the PT's emotional state or mood. For instance, choosing a certain intervention because you are tired or stressed. External sources of bias that can interfere with evidence-based practice include time constraints, limited resources, and limited skill of the practitioner. Interestingly, there have been a few studies that considered years of experience of the healthcare provider and the likelihood of making an error. Although some people might suspect that errors would be more common among novice clinicians, in fact, this isn't true. Errors in clinical judgment actually occurred more often among the experienced providers. Factors that could influence this include information recall and access to current evidence, which is usually stronger among people who have recently completed their education. Also, ascertainment bias tends to be less common among new providers because the new providers have yet to develop shortcuts in their clinical reasoning. Some other flaws in clinical reasoning include something called the recency effect, where the clinician tends to classify patients' presentations according to easily remembered patterns, such as diagnosing somebody who presents with radiating arm pain with cervical radiculopathy versus considering the possibility that the patient may actually have thoracic outlet syndrome. This would lead us to pick examination techniques that exclusively focus on the neck rather than considering the thoracic outlet and testing for that as well. We can also make clinical decisions based on something called representative exclusivity. This happens when patients are lost to follow-up. For example, if we have a patient that discharges themselves early from physical therapy, is it because we made them feel faster than we anticipated and they don't think that they need to come back? Or do they not come back because our treatment was either not helping or it was making them worse? It serves to reason that we would want to work towards reducing flaws in our clinical reasoning. Strategies for doing this include ongoing training and professional development, as well as something called reflective practice. Reflective practice refers to a pattern of thinking where we regularly review our interactions with patients to critique our own performance in terms of what we think went well and where we think we can do better in the future. This process helps to generate a self-awareness of areas where we might be in need of further training or mentorship, and even more importantly, an awareness of situations where we need to be extra careful and take time to avoid possible errors. Our work environments can either be helpful or harmful in this regard. Clinicians need to feel comfortable enough with their colleagues and supervisors to be able to admit when they need help to improve their performance, and also to be able to seek advice or additional training and mentorship without fear of being ridiculed. With the development of electronic medical records, we are also seeing an increase in the implementation of electronic clinical decision support systems, such as built-in prompts or documentation templates that help guide evidence-based practice. This might include certain evidence-based protocols that allow us to select the best interventions. When electronic systems are designed to communicate across healthcare settings, this can also enhance evidence-based practice by improving transition of care from one facility or clinician to another. You are already familiar with the framework for generating a clinical question. Use of the PICO format allows us to focus our literature search and provide some criteria for evaluating whether the studies we find might be helpful in improving clinical care under certain conditions. The P in PICO stands for patient, problem, or population of interest. This allows us to match the individual or group we are working with to the samples in the studies we are using to answer the research question, or the clinical practice question rather. The I in PICO stands for intervention. When it comes to intervention or treatment, when we search the literature, we're hoping to find very specific information about the treatment method that was used, how it was delivered, and things like how often the treatment was delivered and at what intensity. We may also need to consider information regarding costs of care and access to proper resources, as well as any potential side effects and if there are better treatment alternatives that are available. C stands for comparison and often involves weighing the risks and benefit of treatment versus no intervention or a newer treatment versus the current standard of care. O is the outcome of interest, or the result we are hoping to obtain using the intervention. Examples include improved accuracy in diagnosis and prognosis, or when screening for risk factors. We might also be seeking ways of reducing the need for treatment and enhancing return to prior level of function and restoring health-related quality of life. Other possible outcomes include improving access to care for people in need and reducing overall healthcare costs. Here are some examples of clinical questions that might arise in PT clinical practice. For diagnosis, we might ask a question like, which test is better for detecting the presence of a rotator cuff impingement? For prognosis, we could be seeking a more accurate way of screening older adults for fall risk. For etiology, we might want to find evidence that helps us determine whether certain factors cause a condition, such as Achilles tendonitis. As you look at these examples, consider how much detail is included to make each question as specific as possible. This is because the more specific we are, the better we can focus our search of the literature for the most appropriate evidence. Here are some additional PICO questions that look at best methods for prevention and obtaining desired treatment outcomes. In terms of patient management, you should be asking questions that involve the accuracy of examination and patient evaluation techniques. This includes factors such as the sensitivity and specificity of tests and instruments, as well as the best test based on the patient's signs and symptoms. We've briefly mentioned how scientific methodology is a part of physical therapy, whether you're strictly a clinician, solely a researcher, or some combination of both. Let's talk about this in a little more detail. In many ways, every patient who walks through our doors is like his or her own little research study. The early use of a clinical hypothesis is where the PT begins to develop an early working diagnosis based on the patient's reason for referral, his or her history, or a review of their records. Generally, the PT develops this initial clinical hypothesis based on his or her prior knowledge and experience in working with people who have similar presentations. This working hypothesis then helps to structure the examination process. Using the working hypothesis, the PT selects tests and measures that either confirm the diagnosis or lead us to seek other alternatives. It is important that we stay flexible throughout this process so that we can consider other possibilities if the results of our early examination do not match our first suspicions. As we conduct our exam, evidence can assist our selection of appropriate tests and measures. The use of clinical prediction rules can also help us consider how well someone may respond to the proposed treatment. Finally, when using a research framework in clinical practice, we analyze the data we have collected to determine the patient's prognosis, diagnosis, and rehab potential, similar to the way that researchers summarize and present the results of a study. The clinician's summary is usually represented by a patient problem list that can be prioritized according to modifiable as well as non-modifiable factors, including those issues that carry the most functional impact. This allows us to establish appropriate short-term and long-term goals and focus our interventions. We will end this module looking a bit more at some of the challenges in evidence-based practice. The availability of suitable evidence still remains somewhat of an issue. There are areas of practice where quality evidence is still pending. However, we need to avoid making assumptions that certain interventions aren't effective simply because there is no available evidence. It is also important to remember that not all published studies represent quality research. There is something called publication bias. This refers to the tendency of medical journals to only publish studies that present statistically significant or positive research findings. The healthcare and research community also benefit from knowing about well-designed and conclusive studies or studies where the intervention may have initially shown promise but failed to achieve positive results when tested in a controlled environment. This helps to prevent duplication of research efforts and can also help to guide the development of collaborations or larger sample size studies that improve our approach to obtaining evidence. Another factor is delays in publication of results. It can sometimes take a year or more after the data is collected to prepare research results for dissemination, and after that another year or more to see an article actually appear in print. This means that what we consider current research may already be a few years old before it actually gets to us. As PTs, we should also consider how we disseminate our research findings. While specialty journals like PTJ are useful, when PT research only appears in rehab journals, we limit our readership to audiences or people that are already familiar with our field. As the profession's research potential becomes stronger, we should seek broader avenues for dissemination, such as scientific journals at large or specialty journals in other healthcare professions, such as medical orthopedics, neurology, or pediatrics as examples. Remember that we are not the only ones that are seeking evidence. Our patients are becoming more informed healthcare consumers and often come to us with research that they have located on their own. We need to be open to the patient's suggestions, but we also need to be ready to manage challenges that come from trying to locate credible sources. As you know, not all information obtained through the internet is valid and reliable. Without ridiculing anyone, a good clinician must be prepared to let patients know that their opinions and input are valued, but to also be patient and teach them how to sift through the information that they have found in a way that allows us to consider its quality. Sometimes the information that patients find on the internet can cause unnecessary alarm or send the patient on a wild goose chase for unlikely outcomes based on false optimism, poorly designed studies, or deliberate attempts by unscrupulous entities to make a profit from other people's hardships. As PTs, it is our duty to use our evidence-based powers for the greater good. Thank you.